Welcome, everyone. It is my immense pleasure here today to bring to you two professionals we've been working with for many years now. These are orthopedic surgeons who've really taken to heart the question of how can we help individuals understand their bone strength, their bone density, and their bone strength, and how can we help them maximize their bone health. These doctors are Dr. Kimberly Zambito and Dr. Andy Bush. They're both orthopedic surgeons, and they both have become leaders in this country of a new technology, a technology that allows them to measure bone density in a new way, using a system called Rems, which is an advanced system of ultrasound developed in Europe, developed about in 2018. And Dr. Bush and Dr. Zambito recognized the potential of this technology early on and said, let's work with it. Let's bring it to the United States. And now they've dedicated a few years to introducing the U.S. public and the U.S. medical system, introducing them to this new system, the Rems technology, to measure both bone density and bone strength. So I want to welcome you both to this little seminar. And I want to thank you for all the work you've done for women's and for men's health. At the Center for Better Bones, our goal is to help reduce needless fractures, and we really are delighted to have been able to partner with you, and we appreciate all the work that you've done. As I introduce Dr. Bush and Dr. Zambito, I want to tell you that they've now produced two important documents, two articles. This one is an article on the practice procedures, what parameters, what guidelines should be set for this REM testing. It's for the medical community to try to establish some guidelines for the REMS ultrasound testing. And this was published in a journal called Bone Joint Journal. And it really is a very instructive manual. We hope it's going to make a difference, and I believe they're going to tell us about the difference that their work is making in introducing this new radiation-free technology to assess bone strength and bone density. And they've also published a very nice article in the American Academy of Orthopedic Surgeons, again, which is an article which discusses this REMS technology. So they're pioneers in the field, and they invite us all to be pioneers in moving ahead with a new technology, a new safe technology, in my mind, a more effective technology for measuring both bone density and bone strength. It's our pleasure that both Dr. Zambito and Dr. Bush will be coming with us to the Better Bones retreat workshop at Kripalu. This is happening in May, this coming up May 14th to the 18th. It's a 5-day retreat. We'll be giving the Better Bones Solution sessions, the whole workshop, and they will be available for REMS testing. If people want to look and assess their bone density and their bone strength, the unique opportunity to test bone strength by this REMS technology. So with all that, I want to welcome both of you, Dr. Zambito and Dr. Bush. Thank you for the time that you're giving us today, and also for the courage to step out and say, look, there's a better way to do this, and we want to help the public to understand that, and also help the medical system. So congratulations, and thank you for being with us. We are fascinated with REMS technology. I've seen the problems with bone density for 40 years. I was at the very first meetings at Harvard, the 1980s, when they said, we are going to be able to predict two fractures because now we know how to measure bone strength. And 40 years later, we see that isn't true. You cannot predict fracture by bone density, by the standard DEXA bone densities that we do. And so I'm delighted that there's a new technology out of Europe that says, look, we've got a better way to measure bone strength and predict fracture. It's a highly studied science. And let's have Dr. Zambito and Dr. Bush tell us what's new in this REMS technology and how is it coming along to being accepted here in the U.S.
Dr. Brown, thank you so much for inviting us to sit with you to discuss this. And thank you so much for being a pioneer yourself. If it weren't for you, we would not have this technology really pushing its way through our general population. So thank you so much for giving us that platform, but also for being an advocate. We much appreciate appreciate you.
Oh,
And I also want to thank the patients. The patients are really the grassroots effort to get this accepted into the medical community. Recently, an endocrinology team reached out to me to ask me to give a talk about Rems technology because their patients are asking them about it. And so they're at hey, something's going on here, is really pushing them to be curious to learn about this new technology. So thank you to you, and thank you to your team, and thank you to all the patients who've been working with us and really pushing this new technology forward in the US.
my patients and my clients have been really delighted with your results and delighted with the way you help them understand their bone strength and the parameters. Yeah, so it's very nice to be on the forefront. And let's see what we know, what else we know now.
No, yeah.
See, I agree with everything Dr. Zambito just said. I've seen the
Yeah,
same
yeah.
thing. Patients are even a number of patients, and I have a bone health practice, so the folks who come visit me actually become patients. And they are the ones that you refer to me, or others come to me, and they put their trust in this because of recommendations made or what they're seeing other individuals are saying. And that's really the grassroots movement that's going to push this. And I think Dr. Zambito and I have the same philosophy as far as taking care of these folks, where this is a new technology. It's not being promoted by traditional medicine yet. So there's a question of what is this? Is it really valid? So I think it's very important to make sure that we do explain that. We explain what it is. Sometimes I explain a little too much, but people who know me will understand that. But
Yeah.
we want them to feel comfortable with the technology that, yeah, this is not only a correct way, this is an outstanding way of assessing bone. And then what do the results mean when you get a result of something as a fragility score? What is the implication of that? So again, it's important for us to give that educational component because at this point, REMS is still considered new.
And it's a sophisticated technology. This is not something that just popped out of a hat. Ultrasound's been used for 40, 50, 60 years, but now they've perfected it. They've developed a new technology with artificial intelligence, with all this capacity we have to distinguish when we send a sound wave into something, what bounces back and what bounces back, what that means. So I think the more we can explain the technology, it really helps people understand that it's not a simple thing. And I find that all of my clients that go to either you, Dr. Zambito, or Dr. Bush, are really grateful. And they're also grateful for the attention and the care you give them, not just presuming, oh, your bone density is minus 2.5, you got osteoporosis, and you're doomed to fracture. It's it's an enlightened perspective. And one of the things we really appreciate, maybe a good starting point, is this is the first time they've come up with an idea that we can test the strength of bone. Actually, and why don't you distinguish a little bit between they test bone density, but they also have a fragility score that they get from the sound wave they put into bone and what bounces back.
There's also a technology called TBS, so I just want to touch on that as well. TBS is a software package that can be attached to DEXA to look at essentially bone quality in the lumbar spine. Unfortunately, the software does not analyze the hip. With REMS technology, we're able to look at the microarchitecture or have some sort of reflection of the microarchitecture through the fragility score in the lumbar spine and in the hip. And when you combine the bone mineral density with the fragility score, you develop a risk classification, and it's a 5-year risk of fracture. So this adds to a better understanding of who is at risk or who might be at risk. And of course, you talk about this, Dr. Bush and I talk about this. There's so much more to fracture risk than bone mineral density. We want to take into account the quality of the bone, the elastic properties of the bone, the geometry of the bone. So it's not just a clear cut imaging result.
Yeah.
We also have to consider the entire patient and fall prevention. Does this person have vestibular disease? Is their eyesight working so they can see where they go? What's their muscle mass like? So the REMS technology brings us one step forward into having a better understanding on how to treat people better.
And you bring up a really good point about the holistic perspective, like just to say this is your bone density, but not to look at the fall risk, for example. 90% of hip fractures occur because of falls. So to pay attention to falls and then all the neurological associates, but also the associated nutritional factors, the emotional factors. That's really wonderful. We've been championing for years, moving to a broader perspective to try to understand all the possible factors that affect bone strength. Yeah, I'm excited about it. I think it holds a lot of promise, and our clients are always extremely uplifted when they see either of you, they understand more and they see the possibility to actually enhance their bone health in even in these scientific parameters of this is your particular measurement.
I am a big fan of the fragility score. For me, that it makes a lot of sense. And I do have my opinions, which maybe not everybody agrees with about T-scores, but I will state them in a minute. But to go back to what you said about the development of technology, Rems is standing on the shoulders of prior ultrasound. There was something called
Okay.
QUS, which was a heel ultrasound that some folks might be familiar with in the corner of some health fairs or something. People are sticking their foot in a tub of water and they're doing a ultrasound analysis of the heel. So that was called QUS. And that was done for many years. One of the problems is everyone's heel is a little different. So the World Health Organization could not establish a uniform spot, a region of
Oh,
interest
I didn't
at the
understand.
heel. So you get a bone mineral density, it's called the EBMD, but it never was accepted because, again, you could not standardize the region of interest. But there was something that they were getting from the ultrasound that was pretty curious. You have a bunch of sound waves that get through, and you can measure how fast the sound goes through the bone and how much gets blocked by the bone. Velocity of sound, broadband ultrasound attenuation, those are just a couple of the sound waves. If you have a ratio of those, you actually have the predictive power of whether that patient's going to break.
Yeah.
And it was noted that it was actually better than BMD measurements done by DEXA at the hip. However, since you didn't have a standardized method of examining the heel, it never really got promoted. Now, my understanding of the history of Rems is that the folks at Echolite were brilliant. They noticed that. And as technology developed where you could start doing echographic ultrasound, because again, QUS is transmission. It goes through the bone and you have to be in a tub of water. Well, you're not going to take somebody and dump them in a tub of water to examine their spine or hips. It's just not practical.
Yeah.
Now you have the ability to bounce sound waves off of bone that interact with bone and come back as an echo. And multiple studies have shown that those sound waves will differ depending on the characteristic properties of the bone. And that's what the stiffness index appears to have been with QUS. So you have this ability to get the sound wave that comes out that's been modified by the bone it's interacted with, and it'll show you, is that bone high quality or low quality? So that's really how Rems developed. And the method, as there's a study that also came about 10 years ago that was done in Italy, which just, for me, this is why Rems is not only the future, but I feel that we're only seeing the tip of the iceberg. But they took a femoral head from somebody who had surgery done for a hip replacement. And they examined it. They brought it to the laboratory. They looked at it. They first examined it with CAT scan, with CT scan. And the CT will slice up that head. So
Yeah.
you'll get this series of round x-rays. At the largest diameter in the middle of the head, they took that x-ray. And it actually looks like a pizza. The cortical bone is the crust, and then you have the trabecular bone, which is the cheese and the sauce. And when you look at the x-ray, it looks like somebody didn't put the cheese on. So we're all going to grab the slice that has the most cheese, and somebody's going to left over with the one with the bubble where there's no cheese. The distribution of bone is going to be uneven. Sometimes it's pathologically, but just in general, there will be a variability in the distribution of the bone. The CT can measure that. So they sliced it up like a pizza, 30 slices, and they looked at the comparison of bone to space, white to black, and it's called the bone volume to total volume. And they got numbers, and it varied depending on the structure. And they put on the graph, it went up and down. They repeated the same experiment with ultrasound. And in sonified, they hit each slice with a sound wave. And the sound wave coming out will vary depending on that structure. They put that on the graph. They were identical. So when we do a Rems, when Dr. Zambito and I do a Rems on somebody, the information that's being harvested, that's being collected and coming out is the equivalent to a CAT scan. It's not just blocking X-ray beams like DEXA does. We are actually getting a measure of the structural properties of that bone. Now, they can't be parsed apart yet. That's still probably going to come down the road, but it's all the properties, the structure, the mineral content, the mineral composition, collagen content, collagen cross-linking, microfracturing, all these things that determine whether that bone is going to fail under load or not fail, is going to fracture or not fracture. And that's a pure number. Now, what do you do with it? The next thing that I think is brilliant that Echolite came up with is, okay, what is clinically useful that's strong? the bone in somebody who hasn't fractured. And now if you want to compare it to somebody weak, what's weak? The bone in somebody who has fractured. Database built on individuals who haven't fractured, they have their sound wave, and they have a profile, an average profile of strong bone. They also have an average profile of weak bone. So the information that we collect during your Rems then, and Rems slices the bone up like a loaf of bread. So every slice then will generate these sound waves that could compare it to this database. And it's either labeled fragile or non-fragile, depending on what it better matches. So the fragility score that comes up on the second page of the report, and again, that's for me, I'm emphasizing that because that's really what I clinically use.
Yeah.
It's the number of slices of the individual's bone that better matches somebody who has fractured. So it's fragile. And that's out of 100. And then that gets put on the graph, which is a database of 10,000 plus people who have been divided up by whether they've broken or haven't broken. And then that fragility score is put somewhere in that graph, and if it better matches bone that hasn't broken, it'll be in the green zone, which indicates there's nobody in that zone who's fractured. If it is in the red, then it indicates that their bone matches the bone in somebody who has fractured, so fracture risk is high.
I think
So
that's fascinating that you explain both the history of ultrasound. For years ago, I thought ultrasound, that sounds like I saw signs that it was a very good technology, but now how they've so perfected it that with the REMS, they've actually studied groups of people to see what kind of signal comes back from those who fractured have it. So it's really a very science-based assessment. I think that we can put a lot of stock in that. And I understand why you'd say this will be a technology of the future.
You're having this information come out that we actually probably don't know how to use yet. Again, I think it was brilliant, the simplicity of how the developers decided to use these databases, which are very clinically relevant. Because again, why would you compare it to steel? Why would you compare it to different material? You compare it to strong bone, you compare it to weak bone.
Somebody who's fractured, yeah.
But there's so much more information in that sound wave that we don't know how to parse it apart, because collagen content, collagen cross-linking, diseases that affect collagen will affect bone. So at some point, I think as AI develops, as computation develops, as computer power develops, again, we're just at the tip of the iceberg.
That study you were talking about, they actually did 4 femoral heads and compared them on CT. But wouldn't it be interesting in the US, considering the volume of total joint arthroplasties we do, if we could do a REM scan prior to a total joint arthroplasty and then process that? But I think it would be cost prohibitive.
No, I think that there's a lot of room for investigation, for analysis. I don't want to go again. You could have an hour just about the engineering or about the topic.
Right.
I talked about it for an hour. There's something called finite element analysis, and it's a computer model that engineers are using to see whether a structure falls down. So when I go into my discussion about fracturing, I say, why are we using density as docs? Engineers don't use that. They're assessing structure. If they want to see if a bridge is going to fall down or a building is going to collapse or the wing's going to fall from the airplane. They're not measuring density. They're measuring structure.
But they look at material too, Andy.
Yeah,
they don't
no,
just, right? So when you look at the bone mineral density, that's your material. If you're going to compare, that's right. That's what I said. It's one of the properties, BMD, and then your microarchitecture, your elasticity. You also have to consider the geometry. So if you're going to compare it, you have to compare it appropriately. Yeah, you can't just say they're just looking at the structure. They're also looking at the material too.
Well, with Rems, what's happening is the density is included in that sound wave. It's one
The
of the
density
properties.
is the fragility score is independent of BMD.
Yeah, well, as a measure, as determining BMD, but the density of the crystals and stuff are in the sound wave. They're in there because density is a physical property of bone. Strength is a mechanical property. So strength is how a material will behave when a force is applied. A physical property is something that the material has. And there are charts where you can compare metal and wood and see that wood is less dense than metal and some of the wood is weaker. But there's overlap where you can have wood that's half as dense as metal, but it has the same strength. And we know that because they build wooden bridges in Vermont and New Hampshire.
Yeah, so how do we apply that to human beings? That's the important thing. Like, how do we apply this to human beings?
Well, the fragility score through the analysis of the structural properties, which are in the information coming out of the ultrasound, and then the computer model that the Echolite people, folks in Italy, have developed is basically, again, something that's clinically very useful. Now, what I was going though with the FDA, again, this is my own thought, but I think this is important because there are programs that are developing finite element analysis, what the engineers are using to assess structure. They're applying it to bone, and it's incredible. But the problem is it's CAT scan based. It's high radiation, and then it's limited to Harvard or Johns Hopkins or USC. So it's not going to, doesn't seem right now to be a general screening tool.
To me, this is extremely important because I see in the literature a tendency to CAT scans, and it terrifies me to think that they're going to start suggesting that CAT scans are the best way to measure bone strength. And so I personally, I welcome all of you who are listening, pay attention. This is a fascinating new frontier with the capacity of measuring both bone density and bone strength at the same time with the technology without any radiation. That's why we at the Center for Better Bones take all the trouble to work with these great doctors and to bring them to our retreat. And if you're enjoying this little conversation, come to Kripalu May 14th. We're going to do the Better Bones solution, and Dr. Zambito and Dr. Bush will be there. I'm sure they'll be happy to chat with individuals, and they'll certainly be available to have this testing done if you decided to have it done on yourself. It's a fascinating new frontier, and I congratulate you both. And I'm glad that we are having a sound alternative to CAT scans because as more and more we see, and medicine admits to the failure of bone density testing, in my mind, there's clear failure to bone DEXA testing, and they're moving to CAT scans, which is a scary thought. We are exposed all too much radiation as it is. So let's go on with our conversation, but that's my perspective on all this.
I don't think CAT scans are appropriate for screening and monitoring over time, but they can certainly be useful for opportunistic CTs. I think there's a role for that, but 100% agree with you that it's not practical for screening and monitoring over time.
Tell us more, Kim, what are the new frontiers in this Rems testing and its introduction here? You've mentioned that some of the medical groups have come to you wanting discussions. We're making some headway in having this being introduced as an acceptable technology.
I do. The fact that the the American Academy of Orthopedic Surgeons, was interested in the information and published it in their AAOS now is a positive sign that people are paying attention in the medical community, and there's a curiosity for that. The big thing that we really talk about is healthcare disparity, and technology like this can reach populations that may not be able to get to the current standard, which is DEXA, but you could take it to remote locations. You can take it to underserved locations where people are underserved in the medical community. So I think that is really where we're going to see this explode.
And also if people have implants or if they already have different surgeries, if they have arthritis.
Exactly. Even pregnancy. There is a very rare condition, or at least we think it's very rare, right? And that's transient osteoporosis of pregnancy, which can occur during pregnancy and during lactation. So it really expands our ability to monitor bone health through the ages and through various medical conditions. It's also been shown to be more reliable in people with type 2 diabetes and with chronic renal disease.
Oh, good. Yes, I saw many of those mentioned in this article, and I would say again, it's groundbreaking that the traditional medical societies are looking at this technology, accepting the articles that you two have written, you and your European colleagues have written. So we have hopes that we're thinking we might be making some ground and changing the way we assess bone strength.
I think that enough people recognize that density really alone is not a good method. The numbers out there are 40 to 70% of people who sustain fragility fractures do not have osteoporosis.
Yes, exactly.
Yeah.
No, and some of the European studies show 80% of the people that fracture do not have a T-score by DEXA that would be qualified. And in fact, our argument here at the Center for Better Bones is we need a better way to define osteoporosis, and we go back to the only proof of the pudding is needless fracture. And we're just understanding the amazing order and intelligence of the human body. We're now with the new science, we can peek in a little more, understand a little bit more, but the body's pretty amazing complex. And bone is a great way to understand. We're just starting to just basically understand the magic of bone and how it maintains its strength and renews itself every single day. People who might get the test, do they have to prepare in any way? People that might be coming to Kripalu, do they need to make any kind of preparation for this?
I usually tell people in terms of preparation, you want to make sure you don't eat or drink about 2 or 3 hours before the scan, simply because we are pressing on the abdomen for the lumbar spine evaluation, and pushing at the L1 area close to the rib cage might be a little bit uncomfortable if you gorged yourself on a meal.
Okay.
Gas
Yeah,
makes the test a little harder too.
gas too, but our intestines are working, and that's a miracle of the divine as well. But
So we
loose
avoid
fitting,
eating maybe 3 hours before. Okay, that's a
correct.
great
Avoid
tip.
eating or drinking 3 hours before, loose fitting clothing. And I really ask people to make sure they're wearing underwear.
Yeah, underwear.
Please.
Great. So that'll be easy enough. And it just takes a few minutes. Is that right? Just a few minutes to do the test?
The 20,
Cor-
20 minutes for the three, we do three regions. We do the spine and both hips. So I think it's about 20 minutes. If everything, sometimes you have to repeat it, maybe a little longer, but that's what I find,
And
find
actually,
interesting.
Dr. Bush is reminding us they do both the spine and the hip, and you get these wonderful, colorful explanations of the bone strength that is discovered and the bone density. So it's really like an educational adventure in itself. And working with either of you is an educational adventure. Even if the client only has 5 or 10 minutes with you, every single client reports that they understand more now and they have a greater sense of the possibility of what they can do.
Oh,
And
thank you.
yeah.
We have downtime as because REMS actually will calculate. So when we're doing the REMS examination, we have to give the AI a profile that it recognizes. And if it doesn't recognize, it's going to make us do the test over again. And then also it has to collect enough information. There's the signal to noise threshold, ratio threshold has to be met. If the signal's too noisy, the AI will also not accept it. And that DEXA doesn't do that. DEXA you have a DEXA and it's up to the interpreter to say, hey, wait a minute, there's something wrong with this exam. Whereas the AI, if it's not happy, if we don't make the AI happy, then ain't nobody happy. And we have to do the exam over. So while it's processing, we have time to chat. So that's when I give my information overload to my
You know,
patients and
you bring
clients.
up an interesting point, Dr. Bush, that some of my clients have found other individuals are buying these REMS technology machines. Often, most times, they're not health professionals. They might run a sports shop or nutrition, not even nutrition, but more a fitness center, or they happen to have the funds to buy this. And because it's largely based on AI, they're apparently able to do the test, but we find a real problem with the people come back and they don't know what to do with their test results. What do you think of the future of this? What kind of qualifications we tell our clients, go to Dr. Bush or Dr. Zambito because they really understand this technology. That's what we say. And that's why we offer in Kripalu in Western Massachusetts in May, you can come and be tested with us. You can get a deep understanding of it. But what suggestions would we give to the public at large that says, hey, this is interesting. I'm going to go find a REMS technology someplace to measure my bone strength. What would you have to say? What should they think about?
I think it's encouraging that the technology is gaining popularity, but I do think you need to be aware of the fact that as you do more REM scans or any type of skill that you start with, you're using training wheels, and as the time goes by, you become more proficient into an expert range. Even though the REMS technology was marketed as being foolproof, it really isn't foolproof, completely foolproof. You do want to have somebody who knows what they're doing, who understands the anatomy of the human bodies, particularly the lumbar spine and the femoral neck. And you want to understand the use of the actual technology of ultrasound and have a basic understanding of what that technology can do, including focal depth and focal point and depth of the region of interest. So you want to make sure people know what they're doing in regard to that as well.
Okay, and how about you, Dr. Bush? What do we think about?
No, I'm agreeing with what Dr. Zambito is saying. It takes just like anything, you have to have experience to. Now, there are people who are very easy. The REMS, after you do 10 REMS, there's some people come in, you can just do it. It actually is that simple. Now, when you start getting scoliosis, you start getting degenerative changes, you get someone who's bigger or somebody's really small, then you have to understand the balance between the focal setting, depth setting, in order to get a valid study. One of the areas where a mistake can be made with REMS, and it's really the only place, is what Dr. Mizambito had mentioned is the focal setting, depth setting, because the AI relies on us to do that appropriately. And it's kind of straightforward. It's actually having the red line and then the image, the profile of whatever we're examining in the middle portion of the screen, because we can put it at the top or we can put it at the bottom. But if you're doing that, then you're not optimizing the mathematics, and the results probably will not be correct, definitely not reliable. So that is really the one mandate, but there is a trick when you're dealing with somebody who's either very large or very small, having being able to balance the settings so that you're in that middle portion And then also like a scoliosis, it's just challenging because you have to be able to twist your arm to follow the curve. And when you first put that probe in your hand, you're terrified of it, and there's no way. But after a while, that probe becomes part of you, and you're
Yeah,
looking at the
yeah.
screen and you're just moving your hand around. So it takes time. And unfortunately, right now, there really isn't a formal training program. When somebody
That's
buys a
um,
REMS, they get somebody come over to show them, but then that's done. And I know the ISCD has a DEXA program, a training program that's not hands-on, but it's educational about DEXA, about the reports, and it's 2 days. And I
mhm.
think it's fantastic. I think Dr. Zambito and I both took that course, and we feel comfortable in reading DEXA scans. Now, I don't feel comfortable doing DEXA scans, and there's a separate course for that. You have to learn how to do that. But again, I think as things evolve, and again, Dr. Zambito and I are working with another group of doctors, doctor out in England, Dr. Nick Birch, and folks out of Australia, and other folks in the United States who are REMS users. We're getting an organization together where we
Yes.
really do want to have something where we can teach people how to use REMS, help them also with understanding it. And then I think the final thing would be the physicians who are doing this can be the people that others can then rely on to interpret the results.
So if someone did get a result from another place and they don't understand how to interpret, they could contact you or Dr. Zambito about helping to understand that. And I did notice that in these 2 articles you published, that there's several European colleagues. And that's such an important thing, that it's like a European and Australian colleagues, physicians who have really, in our minds, stepped aside to say, look, we need to rethink how we're measuring bone strength and bone density. We're delighted to see this move. And we certainly appreciate your efforts to make it available here in the United States. We want to welcome everyone who's listening to come to Kripalu, a wonderful retreat center in Western Massachusetts. We're going to be there, and Dr. Zambito and Dr. Bush are going to be there May 14th to May 18th. We'll be scheduling appointments for REMS. And of course, you're welcome to attend our Better Bones Solution Retreat. Remember, from our point of view, the gist of all this, the purpose of all this, is to set the path to build lifelong bone strength and to really limit the number of these needless fractures. And even if you have fractured, there's so much you can do to build bone strength. So join us in Kripalu, join us talking with Dr. Zambito and Dr. Bush. Should you have questions about your test or want to be tested or have been tested and need an interpretation of this REMS, I cheer you both. Is there any goodbye words you'd like to have to our audience? Any thoughts? We congratulate you for your work. We know you're both hardworking surgeons who set aside the surgeon business, which is a very lucrative business, to actually help the public expand their awareness and the possibilities for truly measuring bone strength. What last minute thoughts might you have?
Yeah.
Well, Dr. Brown, you started going down a little path, and I think we got off at the little topic, but to your credit, you started looking at this 50 years ago, 60 years ago.
Yeah.
And back then, people were probably looking at you saying, what's she talking about? And now it's come full circle, and we realize how important the skeleton is. And I think the next step that's happening, it's not just the skeleton, it's the musculoskeletal system. So I also, when I talk to my patients or clients, I tell them, don't think just about the bone. Think about the bone muscle unit,
Yes.
because that's really sarcopenia is probably more of a problem, because what I see in the literature, I see with a lot of longevity medical doctors are promoting, is that it's the muscle loss that results in death and dying.
Exactly. And it's partly because of this bone density machine and that they have focused so much on bone density, when really I've always argued, and these machines I think could measure muscle strength. And that's what we need to show people, that just as you lose bone, you lose muscle. The average person loses 45% of their muscle and 45% of their bone as they go from 35 to 85. We don't pay any attention to muscle. And that, of course, is one of the great surrogates for measuring bone strength. Will they measure muscle strength you think on the REMS one day they will be able to incorporate the muscle content and the muscle strength?
Absolutely. The team at Ecolite has studied the use of ultrasound in evaluation of sarcopenia, and the software package is pending, but I anticipate that coming out in the very near future. And it's so exciting
That's
to
very,
have that added information.
and that's a game changer, because people are not going to be, I see so many women that waste their life on 1% change in bone density or 2% change. It's like a shame to put all their focus on that and not see the big picture. So at least part of the big picture, we always talk about better bones, better body, but we could talk about better bones, better muscle. That's a really clear part of the picture, just like Dr. Bush's. I look forward to that. I really look forward to that.
Yeah, me too. And just so your audience knows, they can find information, video resources, as well as our blog. Dr. Birch, and I author blog posts, which are informative and educational and geared to empower people with knowledge. But also, when you gain that knowledge, you gain peace of mind. And that's really huge too, in terms of taking care of our bones, is decreasing those cortisol levels through gaining some knowledge and empowerment.
Where do they find the blog?
www.qualisos.com. That's QUALISOS.com.
Perfect. So everyone pay attention to that. Go check out the blog. Kimberly, what's the
Yep.
website? Yep.
www.qualisos.com.
Okay.
And for those Latin scholars out there, that means good bone.
No, we really appreciate that. And I want to encourage all of you to stay stronger longer. One really big step is to find out what's actually happening with your bone right now. So come join us in Western Massachusetts, May 14th to the 18th. We're going to do the whole Better Bone Solution retreat, and you will have the chance to have your bone density, your bone strength tested by the Rems technology with our very own Dr. Zambito and Dr. Bush. So thank you again for joining us. We look forward to seeing you in Massachusetts in May, starting May 14th. And to all of you, I wish you lifelong bone strength and hope to see you soon.
Thank you.
Bye-bye.